Thanks a lot for the invitation. I wish I could have been there on site. Maybe next time. I just returned from a business trip to London last night, so it would have been really tight to make it to Seattle. But anyway, I'm glad I can participate online at least and talk a little bit about our experiments on irrigation and especially irrigation associated issues in endoscopic spine surgery. Now, irrigation is obviously something very helpful in endoscopic spine surgery. We need it to keep the visualization, to keep the field clear of blood. It helps if we use the Kerrison punch, taking out bone and so on to wash out these small fragments. And as has been proven by obviously the colleagues present there, it also reduces infection. Nevertheless, on the other hand, we do also have issues which we possibly associate with irrigation, such as headache, neck pain, seizure, visual disturbance, all the way to really severe complications like autonomic dysreflexia. If we take dural tear into account, then there are also case reports about really severe complications such as subarachnoid hemorrhage, hydrocephalus, cardiac arrhythmia, and so on. Together with some colleagues, we published some of that last year, where these colleagues did have these just mentioned severe complications. For instance, on the left-hand side, you see that subarachnoid hemorrhage followed a C7 for amyotomy and also a dural tear happening during that procedure, which then led to a paraparesis due to that hemorrhage. Or on the right-hand side, you see after during a interlaminar discectomy at the level L4-5, also a dural tear happening during that procedure, obviously causing intracranial air and intraoperative seizure and arrhythmia. Now, again, we did also, beyond these case reports, international survey asking colleagues about their complications, and obviously a lot of them responded with having complications such as headache and seizure. So if we sum it up, out of that list right here, we can associate more than 20% of these complications with irrigation issues. Now, when I started endoscopic spine surgery years ago, I was always told to set the irrigation pump at 30 to 40 for flow and pressure. And I've asked many, many times why. I mean, why are these the standard recommendations? But nobody could really tell me that. It's just obviously a common setting of the pump. But I've always been worried because obviously when we have bleeding, one thing we do is increase the pressure. But then again, on the other hand, we're worried about causing these complications. So again, nobody could ever tell me what's safe, like what pressure levels for how long are safe. And I do understand that a lot of times the answer came that it's very individual, that you have to take blood pressure into account and so on. So question is, can we raise pressure to 60? Can we raise it to 90? Is it still safe? What we additionally do to control bleeding is obviously closing the irrigation and working channel, either partially with a cap or additionally completely by putting the thumb on it. So since obviously I could never find the answer to these questions over the years, we finally started with some very basic experiments in Zurich. Professor Farshad suggested a very basic cadaver experiment, which is what we have been doing the last few months. So we did an approach at the sacrum, just opened the sacrum to get access to the spinal canal, and then opened the lowest part of the thecal sac, introducing different catheters intradurally. Obviously, we have 3 pressure probes, which we put to the cervical spine, thoracic spine, and lumbar spine, and also a 4th catheter just to infuse fluid to maintain a physiological intradural pressure. Additionally, we put an epidural probe into the lumbar spine and then sealed it as watertight as possible. Additionally, to these intradural spinal catheters, we also introduced pressure probes into the brain. On the one side, we put an intraventricular probe, and on the other side, a probe into the brain tissue itself. And then we started to use different levels of gravity, 0.5 meter, 1 meter, and 1.3 meter above patient level. And also we used two different pump systems, a non-spine certified pump and a spine certified pump, where we also, of course, set it to different pressure levels, starting from low 30 to 40, all the way up to the maximum of the spine certified pump being 100, and even above that in the non-spine certified pump. And then we just performed different lumbar endoscopic procedures. This is the example of a transforaminal approach, but we also, of course, did an interlaminar approach. And then we just acquired a whole lot of data while simulating these procedures. I'll just quickly go through a few of these results. So here, obviously, we have the transforaminal approach. We were using gravity at 0.5 meter, 1 meter, and 1.3 meter above patient level. And then we looked at the epidural and intradural pressure. So obviously on the left-hand side, the dark gray column is when we keep the system open. And even if we set the irrigation bag to high levels of 1.3 meter above patient level, we do not have a significant increase in epidural pressure. The same accounts for intradural pressure. Now, if we occlude the working channel completely, like putting the thumb on top of it, then obviously this increases the epidural pressure. The higher we set the bag, the more so. At 1.3 meter, obviously we have epidural pressures of above 20 millimeter mercury. But on the other hand, obviously this does not reflect the intradural pressure. Intradural pressure, even if we occlude the system and have the bag set up very high, is still very low, around 10 millimeter mercury, which is certainly within the physiological range. Now, if we perform an interlaminar approach, it behaves basically the same way. We're still using gravity at different levels, and we're still looking at the epidural and intradural pressure. And as you can see, the columns are more or less the same as we have just seen it for the transforaminal approach. So again, even at high gravity levels of 1.3 meter and fully occluding the working channel, we still have obviously pressures, epidural and especially intradural pressures that are certainly within the physiological range. Now we're looking at the pump system. So the two slides about the results right now were about gravity system. Now we're looking at the pump systems. And as mentioned, we have two different pump systems. System one is the non-spine certified pump, where we can also put the pressure level above 100 millimeter mercury. Obviously, we went all the way to 120. And then we have system two, which is a spine certified pump, where the maximum pressure setting is 100 millimeter mercury. But again, it's basically the same thing. If we do not occlude the working channel, then even at high pressure settings, all the way to 120 millimeter mercury for system one, does not significantly increase the epidural pressure. If we occlude the working channel, then of course, the higher we set the pressure, the more so we do increase the epidural pressure. And now we do have values obviously way above 20 millimeter mercury, but still it behaves similar to the gravity system. The high epidural pressures do not reflect into intradural pressures, so the intradural pressures are still within the physiological range. If we look at the system two, the spine certified pump in the lower part of the slide, then obviously, even if we have the maximum setting of 100 millimeter mercury and we occlude the working channel, we still do not see epidural pressures above 20 millimeter mercury. So obviously we're safe on that side. Now this is the interlaminar approach, still the same setting. We're using two different pump systems. We're looking at the epidural pressure, and it's pretty much analog to the transforaminal approach. When we occlude the working channel with the non-spine certified pump, we obviously do get high epidural pressures of above 40 millimeter mercury. Nevertheless, this does not really parallel increase the intradural pressure the same way. And if we look at the spine certified pump, the system two, then even at the maximum setting of 100 millimeter mercury, if we occlude the working channel, we just barely get above 20 millimeter mercury epidural pressure. Okay, so this was obviously looking at the epidural, intradural pressure in the spine. Now we are looking at the intracranial pressure. Again, we're starting with the transforaminal approach, and we're looking at the two different pump systems. And it's basically the same results as we have seen with epidural and intradural pressures in the spine. So even if we use the non-spine certified pump, reaching all the way to 120 millimeter mercury pressure setting, which is certainly something you would barely do in daily practice. But even at that high setting, when we occlude the working channel, our intracranial pressure is still below 5 millimeter mercury. And the same is true for system 2 for the spine certified pump. So overall, even with high pressure settings and full occlusion of the working channel, we still do not get above physiological values of intracranial pressure. Basically the same for the interlaminar approach. I'll just quickly go through that slide to not just body too much with all these different values, but nevertheless, it's always more or less the same message. As long as we stay with a maximum of 100 and 120 millimeter mercury, we do not really get into pathological values. Okay, so this was the first round of experiment where the dura was obviously intact, and obviously we can barely reach pathological intracranial increase of pressures. Now, second round of experiments was more or less the same thing in the presence of a dural tear. Question is, does a dural tear change these pressures? So again, the same thing. We performed an interlaminar approach. We used gravity, but this time including a dural tear, and these are the results from our first round. Now, obviously, there must have been something wrong with the intracranial pressure probe, since it showed low values all the way to high gravity settings. But nevertheless, if we focus on the other values, then obviously on the left-hand side with the intense colors, you see even if we occlude, when we don't occlude the working channel, even with high settings of 1.3 meter, it does not significantly increase the values. Nevertheless, as soon as we do occlude the working channel in the presence of a dural tear, you see how the pressures do increase significantly already with 1 meter, definitely with 1.3 meter. And then the intradural pressures in the spine increase way above 20 millimeter mercury. So now we're definitely in the pathological area right there. Now, this is just one example of the pump system with the same setting, interlaminar approach. We have a dural tear and we're looking at the intracranial pressures. And this is the spine certified pump where we went from 30 all the way to 100 millimeter mercury pressure settings. But as you can see, if you keep the system open, the dark gray column, then all the way to 100 millimeter mercury, you're on the safe side. You do not significantly increase the intracranial pressure, definitely not above 15 millimeter mercury, which is a physiological value if we're staying there conservatively there. However, if we do occlude the working channel, then obviously already at a pressure setting of 40 millimeter mercury, we increase the intracranial pressure above, or definitely above 15 millimeter mercury. By the time we were at 60 or 80 or even 100 millimeter mercury, then we are definitely way above 15 millimeter mercury and thereby way into the pathological area right there. So to summarize these results, what do we know so far? Obviously, the pressure that is set on the pump system does not reflect the real epidural pressure. And as long as we do not have a dural tear, the epidural pressure also does not reflect the intradural pressure. If we do have a dural tear, on the other hand, we have to be very careful in regard to the intracranial pressure, especially when we occlude the working channel in order to control bleeding. So again, just to really get the gist of that, when we occlude the working channel, even at low pressure settings, once we have a dural tear, that does significantly increase the intracranial pressure into pathological values. All right, so that was a quick summary of our results. The question is, what are the consequences of these results so far? So do we manage dural tears differently now? Do we avoid occlusion of the working channel once we have a dural tear? Or should we even stop the procedure early on after causing a dural tear? These are questions that we, of course, ask ourselves. Nevertheless, dural tear is not dural tear. I mean, we can have very small dural tears, mid-size, or even large dural tears. And I think it additionally matters when during the surgery does it happens. Does it happen at the very early stage of your decompression? Does it happen more towards the end of it? Now, for me personally, it did change a little bit my management of dural tears. Such an example of a very small dural tear in the very early stages of my experience, I would have not bothered about. I would not have done anything about it. Now, knowing these results, I would nowadays, or as I have done within the last few months, ever since we have these results, I have immediately covered that even these small dural tears. Not because I'm worried about CSF leaking out, causing pseudomeningocele or infection and so on. I don't really believe in that in endoscopic spine surgery, but I would be worried about, if I still have ways to go within that surgery, about irrigation fluid entering intradurally, increasing the intradural and possibly intracranial pressure. So this is something that has changed a little bit in my management of dural tears, to where now once they happen, I immediately take care of them. Not that I want to achieve any watertight closure or so, as mentioned, just to cover it up, preventing irrigation fluid from entering. All right, well, these were, as mentioned, of course, preliminary results, a very, very basic, simple cadaver experiment, of course, not something that we can extrapolate into daily practice so far. And of course, it was already a big organizational logistic experiment. So it took us quite a bit of time, but still, we of course could not perform like real full-time procedures for every different setting. So we do have quite a few limitations in these experiments so far, but I think it's a start into investigating these issues of irrigation related complications. So summing it up, again, when we keep the system open, we have very little risk of causing any of these issues. But once we do have a dural tear, we have to be very careful with occluding the working channel, or alternatively thinking about repairing the dural tear immediately. Thank you very much.
Hey Vince, really nice talk. I'm sure with that. Did you guys look at all if there's a difference if there is an arachnoid violation or not? You know, often, as you know, when you have a dural tear, the arachnoid can be specific. And my second question is, do you think it makes a difference also if you're in the cervical spine versus in the lumbar spine?
We haven't specifically looked at just opening the dura, trying to keep the arachnoid membrane intact underneath. So I can't tell you anything about that. We have done the experiments for thoracic and cervical by now as well. I don't have all the parameters or the statistics yet. From what I can tell, it's more or less similar to the lumbar spine.
Vincent, Mark Mahan. A quick question. You talk about occluding the working channel, but oftentimes you're going to have to occlude the working channel to introduce tools down there. Are you talking about both ports?
Yeah. Like the occlusion was really occluding the second irrigation channel and completely occluding the working channel.
So I would presume from your data that you could extrapolate and say that as long as one of those ports is open, you're not necessarily it's the same thing as being open, correct?
Yeah, I mean, like you said, if you introduce a big instrument that completely occludes the working channel, you basically, of course, have the same effect. I mean, we have, I think in the cervical spine, we additionally did that experiment of establishing a second port just to let the fluid flow out and see if that makes a difference when we introduce instruments. We have additionally done that too, that we looked at pressure changes while introducing different kind of instruments in that lumbar spine too. But as said, I haven't looked at all the data yet, but we have done these experiments for the lumbar spine as well.
Vince, thank you so much. I mean, we would look forward to that publication. I think, you know, that kind of research is what endoscopic spine surgery really needs right now, and I applaud you for participating in these kind of studies.
Well, thank you. Thanks again for having me. It's always an honor and pleasure. And yeah, maybe next year I can make it to Seattle. Would love to come.
Thank you, Vince.
Thank
So
you.
we're going to move on to Ray. Ray's going to